Thank you, Andy, and good afternoon. I'm privileged to be the first in a team of professionals who are here today to bring you information on the growing public health crisis of antibiotic-resistant bacteria, antimicrobial availability, and diagnostics. My job is to provide you two perspectives. The first is clinical. I'm a practicing infectious diseases clinician. And as a clinician, I realized I'm actually here because penicillin was available and effective in World War II. My father, shown there, Willard Sears, survived World War II because of penicillin in a manner similar to what I'm going to show you on the next slide. And that was the day he was discharged from the Army in 1946. Today he's 90 and doing well. In addition, I'm here as an officer of the Infectious Diseases Society of the Americas to bring to you some policy ideas that we hope you will consider. So this is the clinical perspective of the power of effective antibiotics when bacteria that we are treating are sensitive to the antibiotics that we're administering. It doesn't take a doctor to appreciate that this 4-year-old previously healthy child has a life-threatening infection that ultimately prevented her from swallowing or breathing. Yet with 14 days of penicillin in 1943, she left the hospital well. This remains true today. When we treat serious life-threatening infections for which we have antibiotics that the organisms of bacteria are sensitive, we see these same type of miraculous responses. And the next slide. This shows you the collective power of effective antibiotics. With the introduction of antibiotics, the U.S. death rate due to infections plummeted with a response that has not been equaled by any other medical technology that's been introduced subsequently. Next slide. And this shows you the tragedy of ineffective antibiotics when we're dealing with bacteria that are resistant to antibiotics and we do not have effective therapies for patients. On the left are just a small number of young lives that were cut short, all due to the acquisition of infections with antibiotic-resistant bacteria. For those that survive, many will end up with life-altering disabilities. I'd like to highlight the case of Addie in the bottom right corner. Addie was a healthy 11-year-old girl, loved to play baseball, developed some pain in her hip, and within a few days was in the hospital desperately ill. On the right is her picture when she left the hospital 5 months later with her mother. During that time, she had sequential antibiotic-resistant infections that left her with a stroke, that made her nearly blind and required a double lung transplant to save her life. Clearly, her life and that of her family will never be the same. Next slide. This shows you how fast it can happen. This just depicts one of the organisms we're fighting, an extreme drug-resistant Klebsiella bacteria. You can see in November 2006 in the yellow states is where this organism was detected, and today it's spread across the United States. Next slide. This is a different extremely drug-resistant organism called Acinetobacter. You can see in 1999, very few of these strains were resistant to antibiotics, but by 2009, the latest data we have, over 60% are resistant to antibiotics. These are infections that are causing combat wounds in our soldiers abroad and have caused deaths, so this is clearly a threat to national security. Next slide. We actually don't know how many lives overall have been lost or devastated due to antibiotic-resistant bacteria, but the CDC is working hard to get us the best numbers they can. However, I can tell you that one resistant bacterium, MRSA or methicillin-resistant Staphylococcus aureus, kills more Americans, about 19,000 each year, than emphysema, HIV/AIDS, Parkinson's, and homicide combined. The CDC reports to us that we have 2 million healthcare-associated infections a year with 90,000 deaths annually in the United States. The majority of these are due to antibiotic-resistant bacteria. Next slide. These devastating infections cost us a great deal in our healthcare system. When we compare these to infections that are sensitive to antibiotics. The annual excess cost to the U.S. healthcare system is estimated to be between $21 and $34 billion, with 8 million additional hospital days occurring. Next slide. The IDSA is the largest organization of specialists devoted to the field of infectious diseases. We are 10,000 members strong. We're predominantly physicians or individuals doing clinical research to improve clinical care. Our motivation to be here is simply that our patients need new antibiotics to stay healthy and alive. We have recognized this rising crisis of antibiotic-resistant bacteria that have collided with a decline in antibiotic development. Nearly all major U.S. pharmaceutical companies have pulled out of antibiotic development, and the FDA has been able to approve waning numbers of antibiotics for us to use at the bedside. In fact, between 2008 and 2012, only 3 new systemic antibiotics that treat whole body infections, were approved by the FDA. Next slide. Because we recognized this growing threat nearly a decade ago, in 2004, the IDSA published an advocacy paper titled Bad Bugs, No Drugs, to bring the problem to the awareness of policymakers such as yourselves. However, things didn't get better, and in 2010, to try to address the pipeline failure for antibiotics, we proposed the 10 by 20 initiative, by which we proposed that there be 10 new, novel, safe, effective systemic antibiotics in development and available by 2020. In 2011, we published an IDSA public policy paper titled Combating Antimicrobial Resistance, Policy Recommendations to Save Lives. Some of these papers are available for you at this meeting. Next slide. Just briefly, IDSA recommends the adoption of economic incentives to address the profound market failure of antibiotics. We need new regulatory approaches to get the drugs out to the bedside to clinicians such as myself who need them more swiftly. We believe federal resources can be better coordinated to address these problems. We need enhancement of our antimicrobial resistance surveillance systems so that clinicians like myself know what we're dealing with at the bedside. We need strengthening of activities to prevent and control antimicrobial resistance, ways to contain these organisms and prevent them from spreading across the country, just as you saw on that map earlier. We need significant investments in research so that clinicians will understand what the best practices are to preserve this vital class of drugs. We need a greater investment in rapid diagnostics, so when I stand at the bedside, I can test a patient and understand if they have an infection that will respond to antibiotics versus not have an infection, versus have an infection that will not respond to antibiotics, such as a viral infection. And lastly, while I and my colleagues have a responsibility to use antibiotics judiciously, we also need to eliminate non-judicious antibiotic use in animals and other environmental situations. Next slide. We are very grateful for the engagement of a number of members of Congress and all the work they've done on the behalf of these issues, such as Representatives Matheson, Gingrey, and Senators Brown, Hatch, and Bennett, among others. However, we believe there remain key steps that Congress can take to address antimicrobial resistance. I'll mention first the STAR Act, which stands for Strategies to Address Antimicrobial Resistance, which we're optimistic will actually be introduced this week into Congress. This bill will strengthen federal coordination, accountability, leadership, as well as support antimicrobial stewardship efforts in healthcare facilities. Congress can strengthen the antimicrobial pipeline. Last year, the bipartisan bill called GAIN for Generating Antibiotics Incentives Now was passed as part of a larger FDA bill and provided extended market exclusivity for new effective antibiotics. However, in 2013, we need additional economic incentives and new FDA pipelines, such as the limited pathway, antibacterial drug development pathway, to try to get narrowly aimed antibiotics out to the patients who need them. Congress can increase funding for CDC and NIH to get us that vital surveillance data and those diagnostics that we need at the bedside. And Congress can ban antibiotic use to fatten agricultural animals. Next slide. This shows you the disheartening status of the 10 by 20 initiative. We're almost a third of the way through this time period, and we've had one new approved drug, ceftaroline. Last slide. So we believe our goal is your goal. 70 years ago, we were giving these miraculous drugs, antibiotics, and we're watching their effectiveness wane. We believe by working together that we will be able to preserve this treasure for the future. Thank you very much.
Any quick questions for Dr. Sears?
Quick question. You mentioned that hard numbers are hard to come by. So wondering what it would take to get good, better statistics out there, additional authority of some kind.
I think funding the Centers for Disease Control, that in making sure they have the resources to do the epidemiologic surveillance across the country is what's vital.
Doctor, I have a question as well. You mentioned, maybe it's just a couple of the examples that you chose, but it looked to me like the curve over the last decade of the worsening problem seems to be kind of getting sharper. Is there anything in particular about medical practice over the last 10 or 15 years that's kind of led to this problem getting worse?
Well, medical practice has been greatly facilitated by antibiotics. A lot of the therapies that we take for granted, the ability to have transplants, to have complicated surgeries, to get chemotherapy, has all been facilitated by having effective antibiotics. With the rising tide, we probably view the most dangerous organisms as these multidrug-resistant gram-negative rods, which are a couple of which I highlighted as spreading across the United States. If we lose control of those, we will lose the ability to have those specialized therapies that we so treasure in this country. Thanks.
There's one more question.
Oh,
I think we have time.
Oh, sorry.
Given that a lot of the nosocomial infections, or that a lot of the antibiotic resistance comes from the hospital itself, how effective do you feel like targeting the hospitals has been, and have you reached the limit of the effectiveness of actually trying to treat, contain within the hospital?
No, we haven't reached the limit. We've been able to show that if you take new approaches, you can dramatically decrease some of, for example, Staphylococcus aureus infections associated with line infections. With some new approaches to protecting ourselves, monitoring, alerts from people, watching people doing procedures, we've almost eliminated them in hospitals. So with additional effort and funding and studies to understand what we can do to contain these, I believe we can succeed. Yes.
Last week there was a somewhat breakthrough study that was published in JAMA that talked about preemptive antiseptic washes and preemptive antibiotic creams put in the nostril to reduce hospital-acquired infections. I wondered if you could speak to a little bit about that mechanism and how it contribute or not contribute to antibiotic resistance.
Yeah, so there have been approaches used. I'm not familiar with that particular article, but approaches used in terms of bathing individuals, particularly coming into ICUs, to try to diminish, exactly addressing your question, to see if we can diminish the rates of colonization with the resistant organisms or eliminate them from the nose, which has actually been a source of spread and a cause of, or associated with, onset of infections. These are all labor, time-intensive efforts, and so we need good research, such as you're citing, to try to figure out how best to implement these types of approaches. Thank you.